Well, thank you for recording in progress. Thank you for having me again at the ICANN Echo. I appreciate being able to be here, be part of your group for a little bit. I'm going to talk a little bit today about the lived experience perspective and as it relates to CBT for psychosis. And this is something that I've been looking into for a little bit of time. In the area of psychosis, particularly CBT, there's a great deal of influence and interest in having a lived experience perspective introduced. I was at a recent conference and there was a lot of information about this. And so I decided to do a bit of a research review. And what I'm going to present today is some of the findings from that, and then just sort of thinking out loud as I go through the slides about how can we improve the treatment, the cognitive behavioral therapy for psychosis treatment, having this information. So I'm just going to talk a little bit about what we mean by lived experience, and then to review the feedback as it relates to improving practice. So if we think about it, and I hadn't thought about it in this particular way until I read this Fusser-Poli article that I have listed here, much of what we have learned about psychosis, of course, comes from a top-down kind of perspective, right? So from theory, early theorizing, research, and then like how does that apply to someone's lived experience, very academic and kind of, the language is very clinical and technical. It makes sense. We learn a lot from that, but there are limitations. And in this review that I have referenced here, they kind of bring up the point, perhaps we could look at it from the bottom up. Let's look at the experience of psychosis from people who live with the experience of psychosis. And so they refer to individuals in this way as experts by experience, and they offer their perspective on experience of symptoms, treatments, living with the experience of psychosis. And I've used the term lived experience here, but it's also the term service user is used here as well. And it's not unlike you think about other products, service users kind of test it out and give you feedback. So it's kind of something similar here, only looking at CBT. So if we look at it in the broadest sense, do service users like CBTP? Generally across studies, CBTP is reviewed pretty positively. Anywhere from 70 to 90% of folks say, yep, like it, it's good stuff. But there is a caveat here in that the folks who complete these surveys were also therapy completers. And so, you're choosing from the folks who have gotten through it and agree to do the survey. So you're likely to get a little bit more of a positive view. But the researchers over time have also looked at more in-depth kind of qualitative studies to say, well, what can we learn from the work with CBT and from individuals with lived experience to maybe improve our practice? So one area that kind of strikes me right away is like, how do we define success or outcome? So we talk a lot about recovery in terms of psychosis, and how do we define that when we're doing work, when we're doing research, when we're looking at clinical outcomes? And if we just, and this is a very broad generalization, but in general, we tend to look at kind of clinical and economic indicators typically, right? So is there symptom reduction or remission? So those are the PHQs and the GADs that a lot of places use. And then do we reduce hospitalizations because there's a real economic impact of that? When you ask folks with lived experience, and the Law of Morrison is a Delphi study that looked at it, what they really, when they talk about recovery, it's about having a personally acceptable quality of life. So life is meaningful, and then feeling better about themselves. Those are the things they would like to strive for. So one way that service users or those with lived experience have influenced the field is by developing an outcome measure specifically for CBT for psychosis called CHOICE. And this was co-developed with a number of individuals who had gone through CBT with lived experience and then CBT therapists. And they identified in the long form 21 items and then short form 12 items that get at some of those characteristics of what's important, like how to solve problems, how to live in their life. And in particular, in this measure, there's a measure of personal recovery goal. So that's always in the mix when looking at outcome. Am I getting towards the things that are meaningful? What else do we know from the lived experience perspective? The Bradman article provides a nice little summary of things that individuals who experience psychosis most want. They want to be listened to, seen as a person, have their experiences validated, be given hope, have more information and choice, sort of empowerment, collaboration in their treatment, and to regain a sense of self and rebuild their lives with optimism. And within that, the conference that I was at recently really talked about validating experience and giving hope in all that we do when we provide CBT. So what do we know about what is perceived as helpful when we talk to folks who have lived experience? And most of the data here comes from 3, 4, 5 studies. One area they talked about is, therapist qualities, and these are just generally, I think, good therapist qualities, being, reliable, having good empathy. With psychosis, being flexible is particularly important by the folks who experience it. Person-centered, genuine, no surprises there, acceptance and non-judgment. One of the big themes that comes across is empathy and the importance of a collaborative relationship, this idea of an equal partnership, a space where it is safe to talk openly about problems, and there's sort of a co-equal partnership at approaching what the challenges are there. So those are the qualities that seem to be really valued. Kindness is also one of the therapist qualities most often reported as valued from individuals who have lived experience. So what about change mechanisms? Some of the things reported in the qualitative studies are, be transparent. Why are we doing some of the things we're doing? Sometimes in CBTP, we'll do strategies for voices, distraction, or other kinds of strategies. Well, explain kind of what's the rationale, how might this work, and check with the individual. Does this make sense to you? Could we try it? That kind of approach. Helping the individual to understand the psychotic experience, really looking at history and context, things that may have preceded the onset of symptoms. We use something called formulation a lot in CBTP, so having a little mini map of how things kind of go together is particularly helpful. Help to improve the acceptance of the psychosis experience. And this is described in the literature anyways, a shift from I must get rid of this experience completely, this is painful, and it is distressing and painful for sure, to a sense that one can recover with psychosis. They can still have symptoms and recover. And adding to that, there can be some positive appreciation of some aspects of the psychotic experience, adding something to what wasn't there before. That's part of the mechanism that seems to help. Lots of use of normalization, helping individuals understand that their experience is on the continuum of common human experiences is really, really important. Little mini self-disclosures from the therapist was rated highly from individuals who showed improvement in CBT. And so this is really the therapist just being a human being, recognizing their own flaws with memory or fatigue or other kinds of things, kind of being part of that same common humanity. That's found to be particularly helpful. CBT in general and for psychosis, the idea of homework is really important. And really, it's just the idea of I continue to work outside of sessions across any kind of diagnostic category, you tend to see better improvement if folks are kind of continuously working on things. And then, of course, CBT has a lot to do with evidence gathering and reappraisal of negative or unusual beliefs. And so in a simplistic way, the voices are perceived as demons and they're always right and always powerful. And some of the work of CBT is gathering evidence about that. Is that 100% true all of the time? Reappraising that, the negative appraisals that happen there. Now, there's a qualifier in that when this is done a little bit too quickly, or you encourage an individual who's experiencing some of these distressing psychotic experiences to change their thinking or challenge their thinking a little too soon, there can be a real pushback. It can affect the therapeutic alliance. And so what we often talk about is, or what seems to be important, is having the person really felt heard and accepted first, and then slowly working together to do the CBT. Let's challenge the way I'm thinking about this, or not challenge as much as let me just check it out. Is this 100% accurate the way I'm thinking about it now? In the conference that I went to that had a number of individuals with lived experience, one of the things that was brought up in this conference was paying more attention and normalizing times when things don't go well, right? These studies say, yay, we like CBT. However, what we do also know from the research is that there are a lot of setbacks. There are negative experiences, misunderstandings with a therapist. This happens. And to kind of normalize that and say, this is something it's okay to talk about. It does happen when things don't go well. Doesn't mean folks failed. It's a process and there's progress in some of that kind of stuff. So really allowing space for that. Another interesting thing that came from the conference that I attended was when things don't go well in therapy, less experienced CBT providers do more techniques. They kind of like, let's do more stuff. The more experienced CBT providers focus more on the relationship and formulation, right? So they go slower, in more depth, take more time, look at increasing collaboration somehow. And when therapeutic ruptures happen, attending to that some. I can say from one of my own experiences, having frustration with someone with psychosis, we were both frustrated. And when I just kind of acknowledged that, apologized for my frustration, we talked honestly about it, really helped our work together, just kind of owning the humanity of this is tough. and we get frustrated at times. So that seems to be an important thing to do. So based on some of this information, how can we improve CBT P from the lived experience perspective, or with information from that? So if I take some of the highlights that I perceive from it, what we can do is work towards really collaborative therapy that helps the person reach their personally meaningful goals. That seems to be really important. Maintain hope so that they can, and to feel better about themselves in this process. All right. So it's not an easy thing, but these are the kind of aspirational things we're looking at. So one of the things, so how do we do that? Well, one thing, so collaboration is really important. What are the barriers to collaboration? And this comes from Paul Chadwick's work. He's done, I think, a great deal of work in this area. So on the one part, the individual you're working with experiences symptoms that may make it just difficult to relate to another person, right? Hearing voices all the time, feeling terrified and distressed, it makes it hard to form a relationship that way. So just having that mindfulness and awareness of that, as well as the sense that the person may have certain blocking beliefs. And by that, he identifies that to mean like believing that, my therapist's not going to believe me, or my psychiatrist, or they're just going to increase my medicines and send me to the hospital, those kinds of things. There can also be cultural and other background factors. So just always being aware, like, what do we need to do to improve collaboration and have that awareness. From the provider side, Chadwick talks about anti-collaborative sort of assumptions that we sometimes hold as clinicians, like, it's dangerous to work with psychosis, or it's my responsibility to make things better, or make change happen, or progress. It's usually defined by my own internal ideas about that, or that I might upset the person if we talk about X, Y, Z. A number of assumptions that lead us to really curbing our practice, or maybe being a bit more controlling, or maybe a bit more rigid at times than we need to be. There's also this concept of privilege of belief that I hadn't really considered in depth before. And this is from the Treichler and Jones article. So Nev Jones has done a lot of work in this area. And it's the idea as a clinician having the privilege of knowing that our own experience of the world, our beliefs and our interpretations will be believed and accepted above others, in this case, the clients, just at baseline, right? And so, and we think about individuals on a psychotic, or in a unit, inpatient unit, something like that. And the risk here is that a person being in that kind of setting may we may be in a position to invalidate their experiences, right? So they may say, I have this business, or I was a professional whatever before I got in here. And there may be a part of us that says, oh, okay, no, you're in a hospital, so probably not. And I can attest to times when I've been on an inpatient unit where I worked state hospital before, individuals made claims like this, some of which were true, professional high-level performers in music, business, other kinds of places. And so really just taking a step back, really kind of accepting, listening to where folks are at, and really honoring, like, what is their experience and how do we make sense of this? They talk a lot about like honoring that ability for them to make meaning of their situation, which leads me to my next slide. There's a lot of good work in the metacognitive area, Lysaker and Rowe do, where they say that one of the core skills in working with psychosis is helping the individual develop these meaning-making skills in therapy. And so from the therapist, or from the client side, helping the client to become an active agent in their own recovery. So choices, making sure there's lots of choices and they can choose, and reflecting back choices they've made and outcomes related to that. So developing self-reflection skills. They talk about developing healthy meaning-making skills. In the cognitive therapy world, that is giving folks room to do that. And so from the therapist side, our role is to be kind of open and vulnerable in the sense that I don't give the person the answer like, oh, I know the answer to your dilemma here, but to work together as a team to kind of figure things out, be that open and curious person. Push against systemic stigma and our own biases that come up when we notice them. Really try to understand their perspective first. And then from this standpoint, at least the folks from this particular therapeutic orientation, helping them with self-reflection and what they call integrating skills. So it's about like, what other information needs to come in here? One of the things we do with CBT is say, could this be related to anything else? Come up with an alternative explanation for things. And that's one of the strategies we teach. And from this standpoint, it's less about, I want you to think my way as a provider because I have the right answer, and more about, what information would help us figure this out. And then let's pull the information and then see how it goes together. We can together figure out an answer, a solution, a direction, something like that. So that's the sense from that. And then as providers, how do we know? Usually we know when we're stuck because, we're frustrated. We feel helpless, and our behaviors may be a bit more closed or rigid when we're doing things. And Chadwick and some of the others from the lived experience world say, ask yourself, what's the source of my frustration? In this moment, what do I need? What am I lacking? And then back to collaboration, what would help restore collaboration here? Chadwick also has some positive assumptions that supports the collaborative mode. And so that is, people with psychosis are human beings at the core, very positive. Psychosis is on a continuum. It's not this way out there experience. It's on the continuum of normal human experiences. And our role as therapists is to really work towards collaboration and acceptance, committing to the process rather than a very specific clinical outcome, and to be, fully ourselves within that. And one of the things that comes up at that hope here is connected to process, right? So acceptance, collaborative meaning making is kind of the direction rather than some very specific outcome. And the other thing that I want to kind of mention with this, in terms of therapy and developing collaboration, it takes time. With psychosis, over 50% said it could take up to a year to really kind of trust, the therapist that they're working with. It's kind of a gift. It's not an expectation within the first little bit of time that you begin session. So just kind of bearing in mind, giving yourself some room with regard to that. So then I kind of, this is actually from the Bradman article. They actually have 10 tips, and I modified it slightly, but here are some just things to think about from the lived experience perspective. I've mentioned many of these here, from collaboration, normalization. You can kind of read through there. Important ones, I think, are really that working towards valued goals with hope and optimism, offer informed choice and shared decision-making throughout. If you get a chance, look at the Gates article and the references. They really did a nice job in the research. It's an article that has to do with a process of reducing antipsychotic medications built into the process of a first episode thing. And what the lived experience participants said is that when they really felt like they had kind of the shared decision-making with it, even if their medicines went up or didn't decrease, they still were good with that because it was very intentional to be a shared decision-making process. And then finally, just kind of, and this is from the Treichler and Jones article, thinking about an ongoing role for individuals with lived experience. It's important for them to have a voice and a choice and a seat at every table is the quote from that particular article. And so this is informing things like research from design to dissemination, having folks with lived experience do that. Training, how do we help trainers train more effectively? We had a discussion at the conference about like, hey, when we're doing role plays and clinicians are doing role plays, are those kind of stereotypes of psychosis, or are there ways for us to improve the way that we do role plays of psychosis so that it's more realistic? How can lived experience inform system factors like inequality to treatment access and social determinants, those kinds of things? And then, from the practice side of things, I spent a lot of time on that today, so I'm not going to belabor that at this point. So anyway, that's my journey through a little bit of a review of the reviewing lived experience perspective and how it might influence psychosis. I'll stop there and see if there are any questions. There's also, just to let you know, lots of references, and at the end I had a few more. There's some links and things like that you can look at related to, stop my share here, from a lived experience perspective.